Dr. Dan Alford brought to my attention a 1995 Institute of Medicine report that concluded that too much emphasis has been placed on protecting society from methadone and not enough on protecting society from the epidemics of addiction, violence, and infectious diseases that methadone can reduce. My name is Aaron Greenblatt. I'm an assistant professor here at the University of Maryland School of Medicine, where I'm in the Department of Psychiatry and Family Medicine, and work primarily in the Division of Addiction Research and Treatment, which is in the Department of Psychiatry. I'm also the director of our Addiction Medicine Fellowship and the medical director of the University of Maryland Opioid Treatment Program. 4 colleagues and I were very pleased to have our article, Overdue for an Overhaul: How Opioid Treatment Programs Can Learn from COVID-19, accepted for publication in the Mayo Clinic Proceedings. My co-authors include Dr. Jessica Magidson, Dr. Devon Gandhi, Dr. Annabelle Belcher, and Dr. Eric Weintraub. Our commentary points out the fact that the structure of methadone treatment for opioid use disorder has changed really very little in the almost 5 decades that it has been in clinical use here in the United States. There's actually quite a bit of variation internationally in terms of the ways that people living with opioid use disorder can access methadone for their opioid use disorder treatment. But here in the United States, really for the past several decades, patients who are accessing methadone for treatment of opioid use disorder, which they can only do through federally licensed opioid treatment programs, have to adhere to very specific and actually quite strict rules to be able to earn the benefit of getting medication to take home with them from the opioid treatment program. Otherwise, they are obligated to come in 6 days a week for treatment, for directly observed treatment with methadone in the opioid treatment program. This approach was designed to protect the individual and to protect the community from the harms of methadone overdose in opioid-naive individuals or misuse of methadone in combination with other drugs or medications that could act synergistically with its respiratory depressant effects. But these restrictions also have been accompanied by some harms as well. The harms of having to interrupt a daily routine to come to an opioid treatment program 6 days a week, the harms of associating with other people who might themselves be struggling with addiction or other social disruptions, and the harms of the stigma of participating in this oftentimes stigmatized treatment. So this pandemic of COVID-19 has really laid bare the potential harms of requiring hundreds of thousands of individuals living with opioid use disorder, many of whom have some significant medical comorbidities, having them present 6 days a week to their opioid treatment program for their potentially life-saving methadone treatment. Obviously, there's an increased risk of transmission to staff and among patients and to the community at large to have large numbers of people circulating around in this way. So in the face of this pandemic, SAMHSA, which is the main government regulatory body for opioid treatment programs, has permitted states to allow programs to give up to 2 weeks of take-home medication to patients who previously would not have been eligible for take-home medication. The idea being that this can reduce the potential for disease transmission within our population. In addition, other federal changes have allowed us to deliver our psychosocial interventions, which previously were mandated a certain number of times per month on site in our OTP. Now we are able to deliver our psychosocial interventions via telemedicine or even by telephone. It's become clear in our clinical experience that some patients actually have benefited significantly from these less restrictive treatment structures, while others have decompensated significantly in terms of their addiction. So what my co-authors and I are encouraging other opioid treatment programs and researchers to do, given this natural experiment of a temporary liberalization of the rules governing opioid treatment programs, is to use this natural experiment to try to get a systematic view using quantitative and qualitative measures of which patients are likely to benefit from these liberalized treatment structures and which patients are likely to be harmed more. So I'm very grateful to those of you who found this topic interesting and worth your time, and of course the co-authors and I are very grateful to Mayo Clinic Proceedings for giving us a platform to disseminate what we think is an important perspective.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.